Thanks. I was just saying that Phil's still working on his camera.
Hear me
Phil's
though?
got technical.
Yeah,
We
we
can
can
hear you
hear
fine.
you.
Hear Phil, but we can't see him.
That's a
But
good
he's
thing.
there,
I'd
like a
rather
ghost.
you
Well.
not see me, but crap.
When I could see him, he was dressed totally appropriate. So I don't know why he's not.
That's
That's
just
not working today.
unbelievable. Okay.
Yeah. All right.
Keep
Well,
trying.
let's get started. Yeah, keep trying, Phil. We'll.
Right.
I guess we'll see you when we see you. If not, we'll holler out to you when we have your questions.
Well, I
Sound good?
can hear you. Just let me know.
Okay. All right, buddy. We'll let you know. Phil, while I'm introducing you, go ahead and introduce yourself real quick.
Thanks. Phil Page, a professor, Franciscan Missionaries of Our Lady University in Baton Rouge, Louisiana, DPT program. Honored to be here. Thank you for all our sponsors, and of course, Ashley for putting this together, and thank you for our hosts, our guests for being here. I look forward to this.
Great. Thanks, Phil. I didn't even mention Ashley introduced me. I'm Rob Manske from Wichita State University and Ascension Via Christi Physical Therapy in Wichita, Kansas. Barb, you want to introduce yourself?
Hi, I'm Kermit the Frog. No, I have a really bad voice tonight, so I won't talk much, I promise. I'm Barb Hoogenboom from Grand Valley State University in Grand Rapids, Michigan. Soon, however, to be a retiree of Grand Valley State University. Anyway, glad to be here tonight, and thanks for coming back, Ty and Dr. Prohaska, and Brady. Thank you for coming back.
Oh, Brady, hop on. I didn't even see.
Really good to do number 2 of our 3-part series. So I hope everybody has a great night. Thank you.
Thanks, Barb. Dan, you want to introduce yourself quick again?
Sure. Daniel Prohaska. I'm a private practice orthopedic surgeon doing sports medicine, Wichita, Kansas, affiliated with the University of Kansas School of Medicine in Wichita.
Great. Thanks. Brady.
Brady Solie. I'm from Twin Cities here, Minneapolis, St. Paul. I work for Twin Cities Orthopedics. Happy to be here tonight. Thanks for hosting me, guys.
Yeah, you're welcome. Thanks for joining us again, man. We really appreciate you doing all these for us. And last but probably not least, Ty Manske.
Hi, I'm Tyler Manske. I'm from Wichita, Kansas, and I go to Valley Center High School.
And Ty, why are you on, Ty? Why are you on with us?
Because we're talking about ACL recovery.
That's right. That's right. So do you want to tell everybody kind of where you're at, or do you want me to tell them?
You got it.
I got it. Okay. So Tyler tore his ACL. Dan Prohaska did his surgery probably a little over 6 months ago, probably closer to 7 months now, I'm guessing. Does that sound right? Closer to 7 months. He started, well, he's been going through rehab the entire time. He's doing, I kind of updated the group about a week ago, kind of where he's at. He's doing, his motion is really good, except for his extension. We're still struggling just a little bit with his last kind of few degrees of extension. We can get it every day that he comes to therapy. We can get it straight, and he's getting it's getting straight quicker and easier. But he still has just a little bit of a flexion contracture. But other than that, everything is really good. His strength. We did a isometric strength test with him right around 6 months, just using a like a strain gauge, and he was at about, was 83%, Ty? 82, 83% of your other side?
Yeah, 83.
Was it 80 or 73? It's 83, wasn't it?
83.
Yeah. So it was really pretty good for 6 months with a quad tendon reconstruction. So he started jogging and hasn't had a whole lot of problems jogging. And then we, or I guess I looked through kind of some literature about return to sprinting because he decided he wanted to try to go out for track at the end of this year. He was really good in track last year. Got fourth and fifth in the 200 and 100 or 100 and 200, 200 and 100.
200.
Yeah. So really good, fast sprinter. And at first he didn't think he wanted to go back out because of his injury, but he decided he would like to go back out for track. So we started a sprinting progression. I don't know if Dan Lawrence is on, but Dan put a nice paper together a while back in IJSPT on return to sprinting. And so we're following that progression. And so far he's been doing really good. So I guess maybe before, I know Brady, you had some questions you wanted to ask Ty, but before we get into that, Dan, when your ACL patient comes back to see you at around the 6 month time frame, what all are you looking at, and what do you want to see, and what what would be like acceptable and what would be kind of unacceptable?
Well, I think the things you kind of outline are the things that I'm looking at: range of motion and looking at how their functional returns starting out. Sometimes we get some really good reports from therapists, and that helps really gauge where we're at. We get some strength testing, and that really helps. And then just visibly looking at their quad, a lot of times you can say, okay, you're ready, or you got a long way to go. And so, you kind of get that status from them, and kind of look at what their goals are, because different people have different goals, obviously. For like Ty, he's pushing it hard, he's working hard, and he's making good progress. And people that, especially the people that are not high school and college athletes, they're just, young adults or adults, they're kind of done with the whole rehab process. So it's kind of talking them into keep going. And I think some of the reasons we want to keep going are some of the things long term that can make a difference in how that knee functions, into their 50s, 60s, and 70s.
Yeah, good. So the strength, you mentioned the looking at their quadriceps. It always surprises me because like Tyler's quadriceps, you can tell it's getting stronger and it's getting bigger, but it's still quite a bit atrophied than the other side. But he was still able to, recruit enough to get the 82, 84%, whatever it was. And when you look at it, you wouldn't think that it's like, just by visually looking at it, it doesn't look like it would get 84%, but he's able to. So it kind of surprises me sometimes how strong they can be, even though they don't look visually like they're that strong. But I also understand what you're saying, where some people come in and immediately that they're not where they're supposed to be. I mean, it's just totally atrophied, because we've all seen that too. But doesn't that surprise you sometimes, of how it doesn't look like it could?
Absolutely. I mean, there's times where you look at it and you're like, oh, you're definitely going to be weak, and you see the numbers and you're like, you're better than I thought. So either people are able to compensate and cheat, or they're recruiting other muscles that we're not really catching the quadriceps strength as much as we think we are. Maybe we're not as smart as we think we are, because
exactly.
Our eyes aren't lying to us. And typically when a muscle is smaller bulk, it's going to have less power.
Yeah.
But doesn't hypertrophy come back slower than torque capacity? In terms of like physiologically, hypertrophy is one of the later things to come back. I mean, I don't know if that's actually true, but I recall that.
Well, that would explain it for sure.
I'm going to look it up while we're
That's
talking. I'll be right back.
I was telling you, Barb, you just like I was just getting ready to write that down because I need to check
That's
that out.
Brady. I feel like Brady knows.
Brady, you got an idea on this one?
Brady, tell us, teach us about muscle physiology.
Yeah, what it's really interesting that conversation comes up, because I fully agree with that too. I think, in general, when we look at some of these reconstructions and injuries, the atrophy is the lingering thing. I know there's been some groups that are looking at some of the the way that the injury affects the muscle metabolism, and just the disuse and things like that. Some groups are showing that you actually get a little bit of cell death, when you have these traumas and things like that, just from the kind of the neural denervation, if you will, where it's not firing and recruiting. There's another group, I think they're at Northwestern, that's looking at activation and stuff like that, and they're actually showing that as the muscle comes back, you actually get all of your muscle activation back. But the problem is that it's not firing as sequenced, and the timing isn't good. So sometimes maybe when we do some of these isometric torque tests, we're actually getting the muscle to fire, but it's more disharmony, and there's some things, torque steadiness, that are coming out. So that would be my kind of thought on like how sometimes they can, produce the torque with still the atrophy there. There's some neural super compensation that's happening. And if you kind of dig into the weeds a little bit more, you probably are going to find more deficits aside from, peak torque and things like that.
Yeah. So Brady, what, besides what Dr. Prohaska said and the things that I mentioned, are there other stuff that you're looking at? The way we set this up, the very first session we did with all of us was like, early intervention type things that you're doing. And now it's kind of middle 6 month, kind of mid-phase time. And then we're going to do another one in, another couple months, kind of more toward end range or end stage rehab. So kind of middle phase, 6 month mark. Is there anything else in addition to what we've discussed that you think is crucial or important to look at?
Well, I think kind of going back to what Dan said too, like I think the older I get as a clinician, the more I value just like really good motion, clean extension, clean flexion. We see all these strength trends, and some people, they get their strength back quicker than others. But I think at the end of the day, like when you get into that 4 to 6 month marks, those knees that have really good motion are the knees I think that just if you follow them forward, God kind of gives them back some of that
Mhm.
strength there versus other knees that, they got maybe 115, 120 flexion, things like that, that they don't bounce back as quick. And I just wonder if some of that's just kind of the brain knows there's some tightness kind of lingering about the joint and they have a hard time incorporating it back into some of the functional movement patterns. So, and hearing what you guys are saying, I agree with all that, but I always like go back to the range of motion thing too. I think that's a really super important criteria when you're looking at entering that next phase of rehab.
Yeah, the basics. Back to the basics again.
Mm.
What's most important? We have just a couple quick questions. Oh, and Phil, you're back on. Did you realize you're on again now, Phil? We can see you.
Yeah.
Gave him a thumbs
Yeah,
up.
okay.
Is this number 34, 35?
I think 35.
35. Okay.
Yeah.
I just had to get that in.
I know. I should have thrown it in. I let it go. I usually bring it. One of us brings it up right when we start, and for some
Yeah.
reason we let it go today. I apologize. I let you down, Phil.
No.
We had a couple questions already. Was this his dominant side, Tyler? If you had to kick a soccer ball as hard as he's pretty. Actually, he's kind of ambidextrous with soccer. But if you were to punt a football, would you kick with your right? Correct. Yeah.
Right.
So it's his side he injured. And then the other question was, is he doing any BFR? He's not right now because he's able to do exercises with kind of full load and everything. But he did do. We did do BFR. Actually, Dan prefers we wait just a couple weeks before we do BFR on the surgery side. But we were doing BFR, actually having him do exercise with BFR on his uninvolved side before surgery, and even after surgery for those first couple weeks, we did it on his uninvolved side. So yes, we were doing BFR, and I'm trying to think how long we did it for, Ty. We did it probably for
A couple weeks.
Well, it was easy, a couple of weeks, wasn't it? I mean, it was like probably 6 or 8. I mean, we did it for quite a while till he could start really pushing some weight on his own without having problems. Brady, before we get into the, I guess Brady and or Brady, we thought maybe you weren't going to make it on. Maybe you forgot because you jumped on at the last minute, and Barbara's going to take your questions.
I was just going to steal them.
Yeah, she was going to steal them. But since you're here, you guys could share them. Do you want to ask a couple of them now?
Well, I'll let Barb ask a couple too, but I'll kick it off here and I'll ask Ty one. As PTs, we all kind of have our bias on our exercises we like and the way we kind of order things. And it's always fun to just ask the athletes, like seeing, where you were post-op on the table, swollen knee, bad motion to kind of where you're at now, entering into running and doing a lot more of these functional things. Along this continuum, if you will, like what are the exercises that stick out in your mind as like being the most helpful to you? Was it, your squatting progression you were on? Was it something that, you guys were doing on the table to get your quad going, or a movement prep for running? Like, what do you feel like sticks out in your mind as like the exercises that really helped you kind of progress?
Well, the first thing we did that I started doing it again once we went to my visit and we were worried about the atrophy was just like Russian stem, because we started with that just to get my quad firing. But the last couple weeks, I've started to do it again at my school, but with weight on my ankle, just to help get that quad to fire more. And it, like, even afterwards, I just feel a lot more stable and stronger after. And then the other one probably is leg press, because we've been doing that since the very beginning and we still do it. It's not anything we ever switched up.
Mhm.
Been progressively overloading it throughout each week. And I mean, I went from only being able to do like 11 pounds, and now I'm doing 120 pounds. And so it's like really one of those lifts where you can really see progression throughout your entirety of your rehab.
That feels good in terms of tracking though too, right? Like it's like, okay, I can see that something's changing. I can do this differently, or I can do more. Yeah, my question's down the road a little bit, so maybe I might let Brady ask a couple first, because I'm curious about the return to running piece, return to sprinting. So why don't you go ahead, Brady, with like the first few days piece of it or whatever.
Yeah, I mean, I guess the other one that comes to play when I think about kind of return to running and stuff like that is, you get into therapy and you have some type of a program that your therapist puts you on. That's, it's new, and you have to do that on your own. And maybe you're doing some of that in clinic too. those first couple of days of starting that running program, like what did you feel after? Did you get sore anywhere? Was there certain muscles that you feel like got fatigued or sore? Did the joint get sore? Did your foot get sore? Like what did your body feel once you started that running progression?
Honestly, so like while I was actually running, it didn't feel that bad besides the fact that I was out of shape from not being able to run for probably 4 or 5 months. But I noticed a lot the day after, like the sides of my knees would be really sore. But I just would take like some ibuprofen or ice it and I'd be okay. But other than that, really, the hardest thing was probably just how like not in shape I was.
Mhm. The reason I asked that question is, every once in a while you start an ACL on their, return to running program. I'm sometimes surprised how fatigued their foot gets.
Yeah,
You
and
know,
their
you,
calf.
they'll say that their calves get
Mhm.
sore, or maybe their arch gets sore a little bit. And, maybe that's a way that, PT to PT, how you progress things and stuff like that. But I was kind of leading you on that because that's something I've observed is you start these running progressions and you're like, wow, my calves are actually fairly deconditioned and out of shape to be doing this too.
He hasn't
Yeah.
complained much about his calf or foot.
Well, we noticed like there was a little bit of difference in my calves.
Oh, your calf size is still,
Yeah.
it's still atrophied on his surgery side.
Difference. But I noticed when running, I didn't really think it was that bad. Like it was just as sore as my legs were from running. So it didn't like stick out to me that much.
So funny story. My question was similar, but how did it feel to run? Like, how did it feel in your head? How did it feel for you
It
to be
felt,
like, wow, I'm running?
I mean, yeah, like whenever you just haven't done something that
Mhm.
like, I mean, I probably did that every day up until,
Yeah.
and just like not doing it for 4 months was definitely weird.
Mhm.
Finally be able to do it was nice. I felt pretty unstable and it definitely wasn't how it was before when I was running.
Mhm.
It feel nice to like be able to run again.
Yep. And then the return to sprinting protocol, kind of where are you on that? Maybe Dad can answer that better, but where kind of are you on Dan's return to sprinting program, Dan Lorenz? And how has that been going? What kind of feeling has that progression been for you?
You
So
can answer, can't you, Ty?
yeah, I don't have the sheet with me. It's in my car. It's in my track
That's
bag.
okay.
But it has like 3 different stages with 4 steps each stage.
Mhm.
And so right now I'm on stage 2, step 4, which like the whole stage 2 is a lot of like form and like getting back the sprinting ability. And for the most part, I've been fine. The hardest part, probably out of all of it, is slowing down, actually.
Yeah.
That's probably like if I slow down too fast, my knee starts to get really sore. And so I just have to make sure I don't like try to like stomp down on my feet.
Mhm.
Yeah. That
Which
is
is really an interesting observation from a patient standpoint, because we know that deceleration is a big
Mhm.
deal. And
Yeah.
we know that deceleration is hard. And so for any of the people that are listening, if you haven't read Dan Lorenz's, it's in IJSPT, his return to sprinting protocol. It's really worth a read. And it's something that comes from a clinician and comes from the place of how do we get people back to these high level activities? And I think that's really interesting, Tyler, that you mentioned that. It's like, wow, the slowing down part is where you do have to put the brakes on and you're
Yeah.
really essentially
Force it.
pound in a little harder.
Nice shameless plug for the IJSPT
Thank you.
article.
Thank you. I edited that paper, so I
Oh,
can
you
say it.
did. I think well, I don't think, maybe I did review it, but it's
Maybe.
a good paper, good progression to follow. Okay, let's get to some questions. We got a whole host of questions, and we'll actually
Yes.
get to one of our articles. Colin Garnick says, was there any neurocognitive training in the initial stages of rehab? We really didn't do much neurocognitive training stuff. And I know I could say I don't have Blaze plods and all the toys, and I know that's not a very good excuse, but we really just didn't do a whole lot. I'm still, to be honest with you, Phil's going to laugh at me here, I think, because we've had this conversation. I'm not 100% sold on the neurocognitive training to be honest with you. And I'm probably going to take a lot of heat and flack
Really?
on that, but we haven't done a whole lot of that. I'm just going to leave it at that. Ty, Sasha, probably, Diggus, are you loading or utilizing creatine as part of your rehab process? Are you taking creatine? You were taking some creatine.
Yeah, no, so I took it before I think I've been taking it since my sophomore year, I want to say.
Yeah.
And so it's not like something I'm specifically doing for my rehab.
Yeah, I've never talked to him about it, or Dr. Prohaska didn't tell you jump on creatine or anything.
Yeah.
You've just been doing it.
Yeah.
Yeah. So it's probably helping. I'm assuming it's helping. I don't know why.
Hope so.
It would be. Yeah. Kim, oh, shout out. Kim, you're out. Kim, you're out. It's an old boss of mine. A great lady. I love her to death. Thanks for joining, Kim. Ty, you know Kim, right?
Yeah.
You met Kim. Yeah, many times. She missed the first talk. She said, what was your injury event? Contact or non-contact? It was soccer. It was non-contact, right? You just landed.
Yeah, non-contact.
Yeah. Adam Rozowski. Did I get that right, Ashley? Rozkowski. Sorry, Adam. Shout out, Adam. I butcher his last name every time. We all agree that motion is critically important. What are we doing for the knee that is stubborn to regain extension, won't hold motion, or for the teenager that is semi-compliant or non-compliant that we don't see very often, who's at risk getting stiff? We've done a lot to try to get his extension back, from Russian stem to prolonged stretching to joint mobilization to anterior tibial glides, external tibial glides, prone, supine hangs, everything that I can think of, we've done. You guys do, Brady? You do anything different? Brady, Barb, anyone?
From my perspective, in my practice, I actually see quite a bit of arthrofibrosis post-op reconstruction. And one thing that we've been doing is night splinting. And we use a device, and not trying to promote it at all, but it's called the Dynasplint. And I think it works really well. And it's kind of a win-win, because I find that sometimes doing low load, long duration stretching during the day, the compliance can kind of be waxy waney. And the Dynasplint you actually wear to bed. So I've actually had some fairly good results just ordering young people or young athletes Dynasplints, and then having them do their low load, long duration stretching in the evening. And those devices run off a spring, so you can kind of grade the exposure to their sleep habits and things like that. Sometimes it works quicker for some athletes than others, but that would be my little plug for some of that. If you feel like it's having a hard time and the capsule's not loosening up, a Dynasplint or a night splint might be a good option.
And so they just wear it literally during the night. They don't wear it during the day when they're doing all their activities. Yeah.
And some of them go as low as 8 ounces of force. I mean, they're just really, really, really minor, but enough to give that low load, long duration stretch.
Duncan Outsley, question for Ty. Have you been doing anything specifically for psychological readiness to return to sport, such as goal setting, visualization, etc.? Are you doing anything for your mind to get you back into sport? He hasn't told, so this, in all honesty, he hasn't told me he's been doing anything, but we'll see what he says.
I mean, I wouldn't say so. I mean, like, I guess goal setting, but I mean, I don't do anything to lose. So,
yeah,
like, obviously, but.
So you are goal setting. We're setting goals, kind of looking at having you do that progression is kind of goal setting, because you get certain goals with the progression that you're following. But you're not like
I'm not like
bed at night visualizing yourself sprinting in perfect form or winning races or anything like that. Standing on the stage, nothing like that. No. Okay. Mary Ingalls. Oh, she said thanks. Mary, thank you, Mary, for joining us. Mary Ingalls says thanks from San Diego. Chris, do you use criteria to meet before the return? Chris Phillips, if you're talking about the return to sprinting progression, yes, there's some criteria in Dan's article that he says you should meet before returning to running, and it's no swelling, adequate range of motion. I think the strength is 75%. You should have at least 75%, I believe, is what the strength was. So there are some criteria that we followed and that Dan recommends that you should follow.
I did put the link to that paper in the chat.
Oh, okay.
The PubMed link.
Cool. Toby DeHaven. Toby, thanks for joining. Did Ty use any Altered G, HydroWorks, or any other tool to help transitioning back to running on land? No, we don't have any of those. I guess we do have a one of our other clinics not far from where we're at has the HydroWorks pools with the treadmills in them, but we didn't use any of those. So no, we didn't use any of that. We have so many questions. If I go through all these questions, guys, we're not gonna. Is it more important to do questions, or should we go to the studies? We probably aren't gonna even have time.
Let's try and hit at least one study, and then we'll come back to questions.
Okay, yeah, we should probably hit some studies.
We have 21 questions in the box.
I know.
I'll try to answer some of them on
Yeah,
top.
we'll start typing some.
All right, thank you, guys. This is the journal club, so we're
do some journal articles.
Going over an article, but thank you guys for all the questions. Hey, Dan Cahill, shout out, Dan Prohaska, Dan Cahill, who we both know is on. Shout out, Dan. He goes by Daniel Cahill for the purposes of the journal club. Dan, you probably knew that already. Okay, so our first article. This is the one I'm going to go with the one because I think it's more controversial, the open versus closed chain article. And I've been actually for several weeks looking forward to this because I know this is a controversial topic. People are either totally black or white against open or closed chain exercise and whether they're safe or not. So the title of this first one is Effective Open Kinetic Chain Exercise During the First Weeks of Anterior Cruciate Ligament Reconstruction and Rehabilitation. A systematic review and meta-analysis by Vincent Fontanier. And I can't pronounce these I apologize, other authors. I can't pronounce your names. Phil, do you want to try? No, you're not even going to try.
I don't even like this article.
Oh, you don't? You're starting out the gate just like, you didn't even save it for just a little bit, Phil, so we could discuss the article before you
hack on it.
Phil, can you hold your anger for a few minutes so we can talk about it just a little bit before you
I'm holding it.
Unleash the wrath.
Okay.
All right. So the reason I wanted to bring this article up is, like I said, it is really controversial, and I don't know. I kind of see both sides of the argument. However, the longer and the more literature I read, I kind of lean toward I think it's okay to do open chain early on ACL reconstructions. And I think the reason, maybe I'm crazy, Dan, that's on with us, you can tell me what you think. A lot of those studies that were done, back in they were late 80s, probably mid to late 80s, maybe early 90s.
Early 90s, yeah.
Okay. They used strain gauges on knee patients who were having surgery. And really what they did was they rated either, typically they rated in some way, like a percent strain or something, and rated it either as a high loading exercise or a lower loading exercise. So they really ranked, what they did was rank them from high to low. There wasn't ever really anything that I'm aware of that looked in those articles that looked at whether that load was bad or not. It was just either high or low. And so even the high, is the high dangerous? Or is it just high? I mean, does that make sense? If it takes 300% elongation to tear the ACL and the highest load exercise elongates it 100%, is it bad, or is it just high based on those other exercises? I may not even be making sense. My point is simply, do we know that those exercises are bad for you, or are they just higher loads with some than others?
I think you also need to consider what our fixation is now in 2025 compared to what it was in the 90s on these graphs.
Yep.
Or, it used to be you'd look at every study and it was like, what is your fixation strength? What is your initial strength of the graft? And I will tell you that I think that the fixation methods we have today are quite a bit better than what we had then. So to your argument, Rob, does it make a difference? Because if the graft is firmly fixed, I mean, you can talk about stretching the graft out, but you're going to have to work pretty hard. If you're stretching the graft out with that exercise, you're pushing it way too hard, or that graft's weak, in my opinion. So, you know, I think there probably is some room to look at that from the perspective of things are different than when those studies were done.
How often, Dan, have you seen someone come back and their graft has I'm not talking where it's ruptured and it's loose now, but an intact graft that has stretched out dramatically? Does a graft stretch out? The reason I'm asking that is because I was at a meeting one time speaking, and I won't say where because I don't want to call the physician out, but a very well-known physician must have heard me, or someone told them that I was talking about doing exercises in terminal extension early and potentially stretching out the graft. This physician sought me out at lunch, found me to tell me that ACL grafts do not stretch out. This person said, no matter what you do to it with exercise, you're not going to stretch it out with exercise. So do you typically see patients come back with a stretched out graft?
You know, I think if you're going to have a stretched out graft, isn't it going to be, I mean, you can talk about graft remodeling, how long it takes and what the time period is. But don't you think that if we were seeing grafts stretch out, we sent these people back some early rehab, you know, the accelerated rehab we had in the 90s where Shelbourne was sending people way back early, you would have seen grafts stretch out with those people because they were pushing it so hard. I personally haven't seen that in my practice. You know, there's people that I didn't do their initial surgery and they come in like, well, that graft's a little loose. When did that graft get loose? Was it put in loose? Was it, did their fixation slip, or was it just always a little bit loose on the graft? You know, and and then we can go on the whole thing of different grafts. I mean, hamstring, quads versus patellar tendons, because I think the quads, if you really look at that critically, and maybe that's this fixation, some of those, you would feel like they didn't have that solid, when you do a Lockman, it's just, you feel the endpoint, it's there. It'd just be a little softer. Is that because you got 4 strands and they're all tensioning a little bit different? So you got a soft endpoint, whereas the quad and the patellar tendon, when you hit that endpoint, it's bang, it's done.
You know it. Yeah.
So, you know, I don't think that grafts stretch out on a regular basis. I'll just put that out there.
Yeah. So what is can we go down the panel, I guess, Barbara? What is your stand on open kinetic chain exercise after ACL? Do you think it's okay? When do you incorporate it? And what's your rationale?
I believe that it can be used effectively throughout rehab, being cautious, especially in the quad and the patellar tendon ones, to protect the patella. So there are times where I don't do full arcs early on and I don't load them heavily early on. I probably lean towards a closed kinetic chain a little earlier because I think it's easier to recruit more muscles. But if you really want quad specific exercises, you probably ought to do a little bit more open chain.
Sooner.
So yeah, I use some short arcs, low arc, like 90 to 30 short arcs and 30 to 0 short arcs early on potentially, and then kind of keep progressing from there.
Phil, are you doing
0 to 90 is fine with no weight. It's when
early. You're talking early going 0.
When you add the weight, we know that you have the anterior translation. And I just go back to what the general is a big proponent of it. Open chain is fine. Just don't overload it. If you want to load it at the end ranges, that's when you do the closed chain to protect the graft.
But 0 to 90 with no weight's active range of motion, Phil.
Yep.
I mean, that's
anyone look to see if the general was on tonight?
I didn't.
You didn't see him. This may be the first time he's not been on.
And is Shirley on?
Oh, wow.
No, I didn't see Shirley either.
Darn it.
Wow. Okay. Lori Bogle's got to be on.
Lori, I said, hi, Lori.
On 35, yeah. Hi, Lori. Lori's been on 35 journal clubs, I bet. Lori's been on 36. This is our 35th. Lori's been on 36 journal clubs. Brady, where are you at with open chain?
Yeah, I mean, I agree with Phil. I think the devil is in the details with like when you define it, you know, like we throw out these blanket statements that open chain is safe. And I think you have to really define that a little bit more. I'm a big proponent of, open chain active knee range of motion. We really don't have any precautions on that. But as you add distal tibial load, like Wilk and those guys looked at, even load placement on the shank, there's ways to increase and decrease anterior tibial shear with some of that. So, to me, it goes back to understanding the biology. And, my group's written on that a little bit, just kind of what goes into graft integration and things like that, and kind of building sound precautions and progressions based on how, the graft heals. And, going back to Dan's point, I think what a lot of times happens with these grafts, and, I've had quite a few cases of this where if you are aggressive with the rehab early on while the graft is still integrating, I think sometimes it isn't even slippage. It's a failure to stay still in the bone tunnel to get that good fibrovascular healing or bony healing. And what ends up happening is you end up with a graft that kind of gets a little bit of micro motion on it, and it doesn't integrate good. And, I've had grafts or people that have come to me with revisions, and I'll be like, well, what happened to your primary? And they go, I don't know. We did an MRI and it just dissolved. And a lot of those are soft tissue grafts, hamstring grafts. And I think what happens sometimes in those cases are they're people that didn't have good integration. Maybe that's a surgical thing, or maybe that's a rehab thing. But at either rate, the body just kind of broke it down over time, and you get this mucoid degeneration of that collagen, and it just dissolves. So I'm a big fan of sometimes less is more when I'm worried about a graft integrating, and really not cycling open chain a whole lot, especially with distal tibial load, because I'm always concerned with fixation slippage. And again, I agree with Dan that I think the fixation's getting better. But, another thing you'll see with revisions is a lot of bone tunnel widening. And Rodeo and colleagues have described that, where you'll actually get this windshield wiper effect at the bone tunnel wall, that you'll actually get osteolysis, and that can lead to pseudo-laxity and things like that. So again, there's a lot of ways you can go with the open chain argument, but I think it's good to have like the detail dialed in when you're progressing that stuff.
I think that's a really good point. I want to just throw in on the tunnels, and this is just anecdotal. I think some of the tunnel widening comes from graft fit. People that put in a graft that's loose and it pulls across easy, it makes your surgery go really quick, but you've let synovial fluid bathe around that graft and you may not get it incorporated. So one of my things that I like to do is I like to have that graft fit in the tunnel pretty snug. And I'd like to have some fixation around the aperture if possible. If it's a graft situation that allows that, because I want to seal up that joint from that graft tunnel.
Dan, can I ask you a surgeon question?
Sure.
So I've been around the shoulder a little bit too, and we talk a lot about these Laprade procedures where when they move the bone block over, the fixation and the compression of the bone block up against the coronoid is really important for preventing osteolysis and breakdown of the bone block. So with the ACL, like say you have a BTB or a quad tendon, we know that suspension fixation is creating a tension line of support through there versus an interference screw is actually pushing the graft up against the bone tunnel wall. Do you feel the compression of a bone screw has any benefit over, just hanging it in there off a suspension fixation?
That's where I think the suspension fixation, when we pull those in, there's friction as you pull it in the tunnel. And so there are times where it's easier to go up a size on that and just pull that and let that graft hang. I do think that does play a role in the fact that you get that synovial fluid around that, bathing that graft. So again, those are the ones I really like a really snug fit. If I'm going to do a suspension graft, which I do, I like that graft to fit in that tunnel so that we're working to get it in the tunnel. It's that tight. So I think you get some of that compression of the graft on the tunnel without a screw pushing on it, just from the graft. As it gets in there, it probably does swell a little bit from the fluid environment and pushes up against the tunnel. At least that's what I hope and think. But I agree, the Laprade A, you got to have that compression or it won't heal.
Good. Who else do we have? Anyone else want to?
Well, I started a survey of the group. I threw a poll out there for the last minute and a half. Open chain. I just said open chain, yes or no, or I'm scared to answer. And we've got 85% yes, 10% no, and 5% scared to answer right now. So
Oh, wow. Wow. So we're pro open chain. That's nice.
I
That's
just-
good.
my
Yes,
answer,
that's
I
good.
don't, I have seen only a handful of ACLs in the last decade because I'm mostly hip, but I'm a pro, but then it depends. Like
Yeah,
you got to be able to activate your quad and actively
Yep.
do the range of motion. I don't,
Yep.
and if it's a good solid quad contraction, I see no reason why you can't do active range of motion 0 to 90
Yeah.
open
Well,
joint.
with Tyler, we did active range of motion early
Mhm.
as tolerated. As I mentioned, he has a little bit of a quad lag still, so he didn't ever get like probably full active motion into extension. But then after, I think it was probably 8 to 12 weeks, he started doing, or actually early, we started doing some isometrics
Mhm.
at like 90. I mean, loading the knee extension machine where it was too much weight, just that he was doing isometrics at 90 and probably about 60. And then after about, I think it was either probably close to 12 weeks or so, we started doing some active light load active through, whatever range he had. So yeah, we did early active range of motion, but not with a distal load to it till closer to 12 or so. And I don't know. I think that's why his quad strength is doing so well, or at least I think it seems to be, maybe that's why, or one of the things why it's doing so well. I have to have a quick shout out. One of our good friends who I don't think gets on very often, Marco Paterno.
Yeah,
is on.
Mark.
Number
Hey, Mark.
3.
Hey, Mark.
Mark, thanks for joining, man.
Hey,
Mr. ACL himself.
that's
Yeah,
right.
yeah. Oh,
Can
well,
I-
hey, just FYI, I've talked to Mark. He's going to come on and hopefully
Yes.
before the end of 95. 95, sorry, 25. I
25.
jumped ahead 70 years.
I-
sorry.
We're
Mark,
back.
Can I just tell
Yeah,
you
we're
what
back.
this article?
Yeah, so let's go.
Oh, yeah.
You can,
Let
yes.
it rip, Phil.
We
Yeah,
gotta
go
move
Phil.
on.
Unload on him.
But I want people to understand, just because it says meta-analysis in the title doesn't mean it's a good paper.
Mhm.
And the problem I have is that what they did was there's a huge high risk of bias on all these, which limits the reliability of the results at the very front end. And the authors are very clear on that. The problem I have is when they do a meta-analysis, they one off all these outcomes, right? So what they did was they actually had 12 outcomes they measured, and 9 of those outcomes were based on one study. When you do a meta-analysis, you should be comparing multiple studies and combining the effect sizes into an overall effect size. Their conclusions are based on the effect sizes of one study when it comes to the laxity, what is this, the Bynum study, the 90N, the IKDC values, the return to play, return to sport. It's all one study. That's not a meta-analysis. This is a scoping review that just looked at how the effect sizes.
Right.
The most number of studies they compared were 2 in 3 out of 12 outcomes. That's
Well,
why
shame on them.
I agree. In PT and Sports, a reputable journal from Elsevier, but to me, you can't make any conclusions. So go back to what you said, Rob. It's a controversial topic. This article is not controversial. It's crap. Okay. The topic is controversial, but you
Yes.
can't make conclusions based on this. I'm sorry. It should not be a meta-analysis.
So their conclusions were the open kinetic chain was found to have beneficial effects on passive range of motion, strength, function, return to play.
Observationally, yeah, but
When performed at least 4 weeks after surgery in programs that begin with closed kinetic chain exercise. But so you're just saying it's crap.
I'm just saying, don't believe all that you read.
Have you ever said that before on the IJSPT JC?
So just to tag on to what Phil said, garbage in, garbage out, right? I mean, not that these were garbage papers, but there
Not
was
at
high risk of bias, there was low heterogeneity, and
High heterogeneity.
high heterogeneity, and they were drawing conclusions on very small and limited parts of the
That's
paper.
correct. Correct.
Great. All right. Can we, you want to go back to some questions, guys? We only have, we've got like about 10 minutes left and we have 20. Oh my God. Now we have 37 questions.
That is the
This
record.
has
That
got to
is a
be a
record.
record. Yeah.
No.
All right. So I'm going to start with my guy, Daniel, not Dan, Daniel Cahill
Daniel, shout
from
out.
Wichita. Phil, do you know Dan? How do you know Dan?
Well, I mean, I don't know how we met Dan. Probably through Mike Rogers.
Through Mike Rogers.
Probably
And
through
by the
some
way, you saw the other
TheraBand.
day, who you saw the other day.
Yep.
Have you noticed a change? This is for Ty, I think. Have you noticed a change in your dietary needs as you've gone through rehab, Ty?
I mean, not really.
You don't feel like you're hungry or you're want to eat anything different? Like you're not wanting steak all the time now?
No, like before I tore it, I was probably more active than I am now, but my diet hasn't changed. I still eat 3 meals a day. I still probably eat the exact same breakfast and lunches I ate before surgery.
Yeah. You guys remember when we had Buddy on and he was talking about diet after rotator cuff repairs, how he said diet is probably like the final frontier, that we don't know about. Do you feel that way, Dan, about ACL? Maybe you do about cuff repairs, but how crucial is diet in all these musculoskeletal injuries?
I think there's a role in it. I don't think that, our American diets are perfect by any means.
Yeah.
And, there's even companies now that market, and it's probably for people that are even worse on their diet than we think they are.
Yeah.
Basically, it's high protein shakes with whey protein and some vitamins to try and make sure that they're optimized. So, and carbohydrates the day before the surgery. There's probably a component to that. I mean, if you have low protein intake and you have bad nutrition, you're a higher risk for a lot of things.
Yeah.
Right.
Yeah. Not just rehab.
I actually just saw a meta-analysis this morning on nutrition after ACL, I believe. I need to pull that back up, but there's some interest in that now. And I thought of Buddy exactly when I saw that paper.
Were you angry after you read that one? Like you were after you read this
I
one?
didn't read it. But I'm not a fan of nutrition research either, because I think that's all hokey too.
Okay.
Send me the paper. I'm curious.
Yeah.
I'll have to go back find it. Yeah.
You send it if you find it. Can you send it to us, Phil?
I'll probably put it in the chat. How's that?
Oh, that'd be great. Okay. Question, Robin Cecil. Robin, thanks for joining. The question is for Dr. Prohaska. I see a lot of athletes who tear one ACL, then another. What genetic factors have you found that lead to bilateral ACL tears in athletes?
I would say that I don't have a strong one genetic factor. I mean, I think there probably is a component to it because you see a lot of siblings, and maybe they've just got the same style of body, and maybe they've got some weakness or deficiency, or they don't carry themselves the same way. But I don't have a genetic factor that says this is going to cause you to have an ACL tear.
What specific, Lauren Lee, thanks, Lauren. What specific strategies do you use to prevent tendonitis during the rehab process, especially considering the return to running? I guess I can answer it first. I think we want to follow a kind of routine that we feel works well. That's so like the one that Dan published that he's used and works well for him. Try to follow it as closely as we can. Make sure that Tyler's still stretching, make sure he's still doing his strengthening exercises, make sure he's, taking some days off so he's not, just constantly going at it and not giving it any break. I think biggest key for tendonitis is just, not overloading the tendon. So giving it a break once in a while, continuing to work it, but give it some rest so you're not completely overloading it. Brady, do you do anything different?
Yeah, I mean, I'm kind of biased maybe a little bit too, but there's been a lot of work out of Delaware around tendons, and my colleague and friend now Ito over at Wisconsin, Madison, he's been doing a lot of work on tendons after BTB harvest, and I think really what it comes down to is early on finding some ways to therapeutically kind of strain that tendon. We know that some slower, long duration holds on the tendon seems to help stimulate some stress relaxation or some pulling of that. So I know the isometric literature has been kind of blowing up around tendinopathy and stuff. And quite frankly, I think it's good stuff. I think it's evidence-based and there's a mechanism there. So that'd be my bias, is a lot of my load progressions early on before adding and running are kind of more isometric based, longer duration holds, things like that. In my hands, I always think the thing that sometimes will flare tendons up the most is jerking activities, things that have like a little bit of a jerk component to it. So I think prepping those tendons for doing some of that with some, isometric loading makes sense as well. And then having good ways to gradedly expose, the tendon to the jerking stuff, that's where the return to running magic kind of comes into play too, and how you progress that.
Yeah. Good stuff. Dakota Bean, thanks Dakota. Does Dr. Prohaska, this is for you, Dan, does Dr. Prohaska go a little higher or lower with the femoral tunnel placement for his ACLs?
I would tell you, I put it, as my mentor said, exactly in the right spot. So, I try to balance it between I'm a Freddie Fu fellow, so I balance it between the two bundles and put it so that it splits between the two tunnels. So I'm probably lower than that. I'm not transtibial, I'm through the medial portal, so I'm a low tunnel placer.
Good. Sorry, my thing just jumped past someone. Lisa Hoagland. Thank you, Lisa. Perhaps I missed this, but how soon after the injury did Tyler receive his ACL reconstruction? Also, were there any other tissues injured or repaired? He had surgery. It was probably about 4 weeks after, wasn't it, Ty? I don't remember the exact date, but probably about 4 weeks. And luckily, there was no other injuries, no meniscus, cartilage damage that could be seen.
I've scanned a few of these if you want me to throw a few out.
Okay.
I think there's a couple down here that I thought were interesting. So like,
okay.
Billy Maroney, Brady, at what point are you pulling the trigger on Dynasplint? Motion loss at a certain time frame, or is it more a feel thing? We've had trouble getting the Dynasplint in a timely manner, and sometimes I feel we raise the alarm too late in the process.
Couldn't agree more. That's where, your colleagues, the surgeons, Dan, you have to communicate openly with them. And the couple surgeons that I see a lot of their knees from, we're very progressive, and we kind of have this protocol where, we're doing some of these neural techniques, trying to knock down tone the first couple of weeks, and then we add in some light overpressure stretching, and then some kind of backpack 15-minute little bouts between weeks 4 and 6. And quite frankly, if they're not showing that improvement, or it's coming around by week 5 to 6, we're usually getting splints. And again, that's if I feel like it's a posterior capsule contracture. The other thing that I always try to rule out is, are they getting anterior interval pinching? Is this patellofemoral hypermobility thing where the legs coming because they can't superiorly glide their patella? I'm trying to rule out some of that and really hone in on individuals I think have a true posterior capsule contracture. And in those cases, it's probably about 5, 6, 7 weeks, and we're trying to get them ordered up to get on them.
Good. Mark Rosales. Mark, thanks for joining us again. What are home exercises you do at home, Tyler? And really, Ty, you're not doing a whole lot. You're really just kind of stretching at home for the most part, because he comes to therapy twice a week. On the days he's not in therapy, he's exercising sometimes in the morning, most of the time at night, or track practice, or after school going to exercise. And then weekend when he can, he goes to the gym as well. So there's really not a ton that he's doing other than some stretching to try to keep his or try to get that last little bit of motion that we're still struggling with. Is that safe to say, Ty?
Yeah, at home it's usually just a lot of stretching.
Okay. Dr. Prohaska, Mark Reinking. Mark Reinking's on, guys. You guys all know Mark, right? All the sports section people know Mark. Yeah. Mark, Dr. Prohaska, what is your trigger for re-imaging when you're concerned about a cyclops?
Gut feeling, if you're not making progression. I mean, the big thing is if we go a series of a few weeks and we're just stuck, or if we're regressing, at that point, it's time to get imaging. If there's steady progression, you just think that there's some soft tissue that we just need to work through. I don't have a strong preference to go that way. And I don't know if I can even say that 100% of the time you'll see a cyclops. You can, but in my experience, sometimes you just get that wall of scar on the anterior, on the backside of the fat pad, and that will hold people too. So imaging may not be the whole answer. In other words, I wouldn't hold back on revision lysis of adhesions if I felt that there was a true captured knee.
And I was going to echo that, Dan, too. The surgeon colleagues I work with, it's kind of funny. Like, we have these email discussions about, when you might get an MRI order for a knee. And my one surgeon, Dr. Chris Larson, who I love and work really closely with, he'll always kind of email me back. He's like, well, if I get an MRI of it, it's going to show there's scar tissue in there because it's a post-op knee. You know what I mean? So his big thing is he's got that I need to feel clinically that it's enough of a problem for me to go in there and say that scar tissue that we're going to find is the issue. Because, you sometimes get an MRI and like a completely asymptomatic knee is going to have a little pseudocyclops syndrome going on in there. And you don't want to knife them again if it's not an actual clinical problem or part of how they're presenting.
Exactly. 100%. 100%. Louise, I think it's Louise Wood, have you tried Mulligan mobilization with movement for extension and weight bearing? I find it effective. I don't know that we've done the exact Mulligan technique, but similar technique and trying to stretch in kind of overpressure in close chain we have done. So probably kind of a pseudo Mulligan. Ty, house hopping, jumping. We haven't done any hop testing yet to see what his like limb symmetry index is, but he's been doing some jumping and hopping. Does that all feel okay to you, or what do you think about it?
It was always like whenever we do something new, it's always hard at first. Like whenever we first got back to jumping, it was hard, but then now like regular box jumps are hard, or not hard, they're easier. But then what was it, last week we started doing single leg.
Yep.
Those started off really hard, and they just get easier as you do them more.
Okay. Guys, we have like 1 minute left, so we got through one article. There's so many questions. We still have 39 questions. I apologize that we can't get to all these. You guys that are on listening are awesome, coming up with all these fantastic questions. Thank God we have one more of these for this trilogy, I guess you would call it, the ACL trilogy.
The trifecta.
Trifecta, yeah, thank you. So thanks everybody, appreciate you all being on again, all the panel, and Ash, you need to close things out before we go?
Thanks for everyone for joining. Sorry we couldn't get to everyone's questions, but if there's anything that we missed where you were asking for something in particular, you can feel free to email me. I'll do my best to get back to you as soon as possible. Otherwise, recording will be up on YouTube probably before I go to bed tonight. So as well as podcasts, etc. So we'll see these guys back here in probably late fall, I think is when we're scheduled. Yeah. So I think Ty will be closer to creeping up to that year mark, and we'll see how everything is going. So thank you everyone, have a great rest of your night.
Thanks everyone,
and we'll see you next month. Thanks.
Bye.
Thank you.
Bye.